To Dr. Sassy in my workshop today on how to build a clinical trajectory for overdose survivors in British Columbia. Um, we really just want to emphasize that this is the end of this. We're not going to have the perfect clinical trajectory in British Columbia. This is really some conversation that we want in workshop style about how we could go about building clinical trajectories in your communities for overdose survivors. So before we begin, we just want to acknowledge that I'm calling today from the unceded ancestral territory of the Coast Salish people, specifically the Squamish, Tsleil-Waututh, and Musqueam people. And I chose this picture. This is actually a picture from my backyard. And it just brings me a lot of gratitude to be able to connect with the land so quickly. But it also, I was looking at this morning and or yesterday morning, and it's just such a picture of the size and the scale of what these trees have to grow through to reach the sun. And I really feel that getting to the point in the conversations of what an endpoint for care is just seems like a mammoth task for a lot of families and folks who experience an overdose, but also to people who are providing care. And so there's a lot of us who've been doing this for a long time and who continue to see this job as monumental. And so we're actually going to come back to the ground today and start talking about what are the fundamental things we need to think about when we're providing care to folks who have experienced an overdose, who are at risk of overdose, and how can we build a system of care that can support diverse folks across this province. So I'll introduce you to our team. First time I've ever co-presented with Dr. Roberto Sassy, who's the psychiatrist and chief at the BC Children's and Women's Hospital. And I'm calling today with my role as Associate Professor in the Department of Occupational Science and Occupational Therapy, but also I'm the head scientist at Foundry, which is an integrated youth service that provides care to young people and families across the province of British Columbia. And so our outline today of what we're going to talk to you about is really just to define what a clinical pathway is and why they're important for people who've experienced an overdose. We're going to talk about types of clinical pathways, specifically linear pathways and iterative pathways. And then we're going to do this exercise together. First time we've ever done it together. So we're hoping to have some feedback about really trying to think about co-designing pathways for your community and using an exercise on a platform called Jamboard, which will allow you to participate and put in your comments as we try to work together to think about what are the important parts and considerations for co-designing pathways of care for your community. Before we begin, I just wanted to share, I was in Belfast last week. I had the privilege of being there for the Integrated Care Conference, and it's an international conference. It was its 24th year. And there are a lot of people working really hard to think about what is integrated care? How do you measure it? How do you know it's happened? And at the end of the conference, a family member got up and said, "You're overthinking this. Integrated care means that the patient and their family have experienced seamless care. They don't know what's happening in the background. It's just working." And I think this is a really important way for us to start today to think about the idea of not just what is a clinical pathway, but what does it mean for seamless care for somebody who has experienced an overdose in British Columbia? What is the ideal dream to help someone embark on a journey who is seeking care and help them achieve the outcomes of care that they are looking for? And in our research, we hear very commonly across this province either two things. We hear that this is a completely complex navigation system or a system that's incredibly hard to navigate. And so this is depicted by this highway system on the left. Or we hear that people are alone and they feel in the dark and they're not really quite sure where they're going and they feel like there's no one there to help them. There is a really great report, if you haven't read it, by Xavier and colleagues from last year about substance use patterns and safer supply preferences among people who use drugs in British Columbia. And there are two themes that come out of that report. Was that for people who are accessing care, they were hopeful that it would be better than it was. I was quite disappointed in the care that is being offered. And also that there's no one size fits all, and that whatever is being provided seems to be fairly systematic and not considering the needs and preferences of people who use substances or are at risk of overdose. We have an exorbitant amount of fantastic research coming out of this province that consistently says the same things, that we need to build better bridges And we need to think beyond just the idea of an outcome being overdose, that we're always focusing on the people who are doing worse and potentially not thinking about the whole continuum of care that could be in place to support people from prevention or health promotion, even prevention, early intervention, and treatment long term for folks who may need to have chronic health support for the remainder of their lives if needed. We also hear amongst a lot of the research that it is really critical that families and patients and their communities and leaders within their communities are involved in deciding what is important and helping co-design these pathways of care within their communities that are fit for purpose for them, and that not one size fits all, that we really need to do meaningful engagement and meaningful engagement, not just in a one urban centered way with a smaller group of folks, but really thinking about who are all the people in British Columbia that may need the services, and how do we engage them meaningfully to design types of clinical care pathways that are fit for purpose for them, their families, and their communities. So I'll pass it to Roberto to talk about what are clinical pathways.
Thanks, Sky, and I think that the way you framed helped us to be humble in terms of the next steps here. And as Sky said, we're not planning to have a final, beautiful, polished product at the end of this, but help all of you to start thinking what would be the elements that you might want to consider when you plan to implement a clinical pathway for people with opioid use disorder in your programs. So the first big definition, again, starting from scratch, is so what is the difference between a guideline and a pathway? So a relatively simple way to separate one from the other is that guidelines are general recommendations that are evidence-based, that will give clinicians a broad set of treatment options. And there's guidelines in a wide variety of components of opioid use disorder, as well as other substance use and mental health conditions. And the overall with the guidelines will give to a clinician is a long list of different interventions that could be used in general to address a particular problem. A pathway, though, is much more detailed and specific. It's a step-by-step process within a particular setting. So the same guideline, for instance, of opioid use disorder might be translated into a pathway that is very different in a place like BC Children's, than in a place like Foundry, than in a place like a school, for instance, where the setting makes the operationalizing those recommendations within a particular setting as what makes a pathway so unique. And what they do at the end of the day is tell a clinician what they should do for a particular patient in a particular step on their journey of care, and not just a general recommendation list of general recommendations there. So we can go to the next one, Sky. Just as an example, in particular for people that are joining us from outside of BC, I'm putting here the QR codes for some of the core guidelines that are available and were created in our province. So the British Columbia Centre of Substance Use has some core guidelines on the treatment of opioid use disorder. It was the very first QR code that you have in there. The second one is for the intoxication and withdrawal management for young people with a wide variety of substance use, including opioids, that was led by Child Health BC with the participation of Foundry and the BC Children's, among other partners as well. And the last one is the BC Guidelines website, which is a large repository of a series of guidelines that has some of the ones that are for specific populations in opioid use, including perinatal use and elderly use in opioids as well. So it might be of interest depending on the scope of the population that your agencies might be involved with. Let's go to the next one. But all the guidelines, again, have to be translated into a clinical pathway. And I'm listing here some of the expected tenets or core ideal components of a clinical pathway. I mean, no clinical pathway might have all of them, but when you start to develop a clinical pathway in your setting, keep some of those ideas in mind, that we wanted to make sure that your pathway addresses the physiological and the psychosocial aspects of opioid use disorder, given the complexity of the problem that we're trying to tackle. So it might be really hard if your pathway only looks at one narrow component of the care. You should use non-judgmental and easy access approach, again, to minimize as much as possible stigma and other barriers to treatment. You should consider the common concurrent medical and psychiatric conditions rather than just focusing on the opioid use disorder, because if you do that, you might end up excluding a large component of your population because of the other comorbid conditions that might be presenting. You should consider also addressing the whole continuum of care. So not only, for instance, the intervention from the pharmacological point of view, but also, people that might need housing in a particular moment in their trajectory of care, or community supports. How would a pathway be offered in an outpatient setting versus acute care versus overdose prevention and so on. Should it be flexible as a consequence of that to adapt to the needs and readiness to change of the person with the OUD, and ideally be co-designed by people with lived and living experience. And that is a core component, because we know if we don't do this, we might make assumptions that are far removed from the actual needs and goals of the patient and their families. So we want to make sure that this is a core component of an ideal clinical pathway. Next one. There's a lot of different components of care that have evidence, again, based on the guidelines that we can take into consideration when we're trying to build a clinical pathway. Some of them are very specifically pharmacological in their nature, including opioid agonist therapy or withdrawal management, naloxone kits, pain management strategies that might reduce the use of opioids or reduce the likelihood of a problematic use of opioids after that, for instance, or the pharmacological management of concurrent psychiatric conditions like depression and anxiety and so on. So those might be embedded within a pathway. But there's also components that are psychosocial, also evidence-based, but are psychosocial in nature, with things such as motivation interviewing, relapse prevention, vocational educational services, family-based support and therapy, psychotherapy, not only for the substance use, but also for the other concurrent mental disorders, occupational therapy, and peer support. So those are all elements that you want to make sure that you have in your mind when you start to design a particular clinical pathway. And next one. And the beauty of the integrated clinical pathways are the ones that its ability to integrate, as the name says, both the pharmacological and the psychosocial strategies. And this can be offered in a wide variety of settings, again, from virtual to outpatient to inpatient, residential, and so on. And the integrated clinical pathways are the ones that get closer to addressing the multifaceted, complex nature of a problem like opioid use disorder. And even though if you go to some of the guidelines and you look intervention by intervention, some of them have more evidence to back them up than others for particular metrics, such as death by overdose. What we do know is that by approaching this from an integrated point of view, you allow a synergistic effect. So, for instance, the pharmacological treatments like OAT have very good evidence showing that they reduce the risk of opioid-related overdoses. However, we also know that acceptance, engagement, and retention in opioid agonist therapy depend heavily on psychosocial factors. Again, barriers to treatment, a stigma, some patient preference or family preference in terms of the way the OAT is delivered and so on. So if those psychosocial components are not embedded within the clinical pathway, you might not be able to deliver an intervention that has evidence in other settings. The next one. So once you're brave enough and you say, okay, let me try to implement a clinical pathway in my clinical setting, and you wanted to start moving in this direction, you might want to be mindful of certain steps that you need to take in that process. So you want to understand your population well, both from the hard data that might be coming from surveys, questionnaires, administrative data, service utilization, and so on, but also from the patient's voices. And you want to make sure that you have some qualitative data from the users and your staff as well to make sure that you understand your population well. You want to understand your program and the community around it. So what is the staff acceptability for some of the components of the pathway that you wanted to introduce? What are your intake and a screening process? What is the availability of resources that you're going to need to link people to as part of a clinical pathway? As part of that, you need to consider your partners, right? Because you might not be able within your agency, within your program, to offer everything that you wanted to offer. So you want to make sure that you have a good link with the community partners, with the primary care, with hospital settings, and so on, to make sure that all the different aspects are addressed. You want to, if you can, identify beforehand, before you implement a pathway, what are the potential barriers to access to care and address those barriers as much as possible. Some of them are user related, might be language, might be stigma. Some of them might be system based that you might need to address as well. Once you have your design of your pathway and you want to test it, you wanted to make sure that you start small. You start with a pilot, and then you measure as you implement it. So you measure fidelity, and you want to make sure that the interventions are being followed in a proper way, and things are not changing, because otherwise you're not going to be able to keep the same metrics in check. You want to make sure that this is sustainable, that your staff can do this, that your patients, your population can benefit for that in an ongoing way, and continue to measure the outcomes. Providing ongoing education and training to the staff is crucial, because again, you don't want your model to start falling apart because people are not understanding that completely, or there's a slow change in the way that the people understand the model, and you're not catching that on time. And then as you measure this, you want to make sure that you keep changing your pathway to keep delivering the goal and the model of care that you wanted. So there's different ways of doing that. The PDSA cycle, the plan, do study what you have done, and then act on that data and modify it again and keep going. That cycle is one of the ways to approach this. But the idea here is that you're going to be changing and adapting your pathway as you receive the information live, to make sure that you continue to address the goals that you set from the get-go. Next one. I think that's back to you, Skye.
I'm going to give you this one, but I can feed off of it if you want. So clinical pathways are important for anybody, and when you are seeking care, and really recognizing that we're coming at this from a fairly westernized perspective. But there are ways of building in different perspectives into a clinical care pathway. It's a very, very medical term that we're using in terms of clinical pathway, but just in general, of a general pathway, what is it that we want to provide care to the person so they get the right care at the right time, over time. And often with opioid use disorders, this is a treatment that is over time. And so we need protocols that are fit for purpose for different folks, but also that have some of the standardized treatment protocols. So Dr. Sassy referred to different types of treatments that have been shown to be effective. And we can learn from our colleagues, for example, support folks who have depression. There are many different ways to support folks who are experiencing depression, many different types of treatments. And there's brand new guidelines that come out actually this week about that. But for the evidence and how we support folks with opioid use disorders, there are these standardized protocols that do exist. And so how do you actually implement those in a clinical care pathway is important, but while considering the needs of the patient, the family, and then the community resources that exist. We also want to think about these as being important, because when clinical pathways are implemented in a youth or in a family patient-centered way, they are shown to lead to improved outcomes and improved experiences for the patient, the family, and the health provider as well. So the health provider feeling good that their implementation of their plan is working, and that the family and the young person, or the family and the patient, feeling good that the care that they're receiving is leading to outcomes that are aligned with their needs. Clinical care pathways also lead to efficient resource utilization. And so we have this concept of the revolving door syndrome that is often referred to when somebody is using high levels of different types of services, emergency department services, inpatient services, different treatment services, without having some kind of efficient allocation of resources that are really designed for that person to support them in a journey that was designed for them. And so once you have a clinical care pathway, it can be much more efficient to allocate resources to where those person's needs are. It also is when Dr. Sassy was talking, I was thinking it's a lot of work to coordinate everything that you were just talking about. And so multidisciplinary collaboration is important, but often we hear teams of people who are supporting folks with OUD or who have experienced an overdose is they're not sure what their roles are. They're doing a little bit of here and there and everywhere. And so clinical care pathways can have a really clear description of what is my role as an occupational therapist on the team? What is the role of a family peer support worker, a peer support worker? What is the role of the person at the front desk who greets somebody into the clinic or into the emergency department for the first time? What is their role to begin that care experience for that person? Clinical pathways have been shown to empower patients and their families so that they understand where they're going. And we have a lot of literature from cancer and arthritis literature about the importance of families and caregivers really understanding what's going on in the journey and the care experience. So when a clinical care pathway is clear, everybody knows who's doing what their role is. And then back to that slide I said, the idea of it being fully integrated and seamless is really the goal, that people feel that they understand that they're contributing in the pathway and things are leading towards the outcomes that were set by everybody involved. And then it also, and I think this is one of the interesting things, and I'm learning a lot from colleagues in Ontario about this, is it allows for continuous quality improvement. And so you're gathering data, both qualitative and quantitative, about whether or not the care that you're providing is working. And if it's not working and that person is not staying on OAT, for example, we just don't end care there, that we continuously engage in dialogue and conversations about how to improve the care experience, and having that built into the clinical care pathway is important. And what I'm learning specifically from my colleagues in Ontario is that if you gather this data in a systematic way as well, you start to understand as well where there are inequities in how clinical care pathways work for certain groups over others. And so if you're looking at it working for one group, but there's another perhaps younger youth that it's not working for, the idea is it's not the younger youth's problems because the clinical care pathway is not working for them. It's how do we make the clinical care pathway better and fit for purpose for them? How do we engage in these continuous quality improvement efforts? Because one size doesn't fit all. So there are two types of clinical pathways before we get into our exercise. And the first one is something that we understand as linear, and I'll show you an example of that on the next slide. But really the idea that there's a start and an end to care. And this is just probably even a very simple version of an iterative pathway. It's a structured multidisciplinary plan that outlines the steps in care for patients with a particular condition, or for someone who's undergoing specific treatment. And the term iterative indicates that the pathway is continuously reviewed, evaluated, refined based on feedback, research findings, or clinical findings, and changes in best practice. And there's this red arrow here because it could be not just changes in best practice, it could be a pandemic that all of a sudden happens, or things that could impact the pathway and how it's existing. These pathways typically involve a lot of people, as Dr. Sassy was talking about, various healthcare professionals, including physicians, nurses, pharmacists, other specialists, peer support workers, and they need to ensure that there's some kind of coordination in the care delivery. And so by following some kind of predefined pathway, it gives health providers and the people in the team to have some kind of standardized way to work towards improving the patient outcomes, reduce variations in practice, and enhance efficiency. So the linear pathway is the first one I wanted to talk about. And I just want to bring this up because this happens to be often the standard of care that we have, not a standard of care. It happens to be the practice that we observe often and that patients report is what their experience was like. And so there's a point of entry where there's screening, where they've entered into a care seeking experience. And so this is often in an emergency department situation, or perhaps even in a specialized psychiatry setting where OAT initiation or opioid use disorder treatment is initiated and offered to the person. So this might be things like methadone or buprenorphine, and it depends on specific factors. There might be some conversation with the patient at this point. And then that person's discharged, and then we wonder about the outcomes of that person later on. And what we know about these outcomes is that they're not great. This is not a very strong approach. We've had multiple studies. This is a recent study by my colleague Boda Nusick, who has really outlined that using several different population-based studies that group has done, that there's just low rates of completion of OAT induction using this approach, and not just getting to the right dose, but just really once someone started in a linear journey and really left to their own to stay on OAT and that being the outcome is tricky and really actually not realistic of what's going on in that person's life. So if we're thinking about iterative pathways, I just wanted to start before we get working. This is not just with opioid use disorder. This is a complex problem, and complex problems need complex solutions, and they need to have solutions that are driven by the community, the patients, and the families and caregivers. And these are just examples of other complex problems that we're dealing with. For example, the climate crisis, global health inequities, poverty and economic inequity, conflict resolution and peace building, public health emergencies, and urbanization and sustainable development. And many of the talks today have talked about a lot of these things, and they add further complexity onto the work that we're trying to do in providing care, because we're not just providing care to folks who have one opioid use disorder. There's a lot of other factors that are contributing to the support that they need. And so there's also complex types of care, and so we're not the only health type that is providing care that is complex to this population. There are many types of chronic disease management situations where we think about what that would look like to provide care and coordinate a multidisciplinary approach to folks who experience, for example, diabetes or kidney failure or cancer. Complex care is, if anyone is ever dealing with this or working with frail elderly patients, this is a really complex disease management approach as well. And then end of life and palliative care is complicated, and anything with complex medical complexity with children is for sure something that we would all identify. I added transitional care as well, and integrated care for behavioral and medical conditions. And really these are types of conditions we also work with, or types of people with these conditions that we work with. But really anytime there is a transition in types of care, it could be through services, but it also could be developmentally as they age out of care, for example. What does that look like moving when you become an 18-year-old? Where do you seek care? Or if you become 25-year-old, where do you seek care? As you move through these different types of transitions in the healthcare system, how do you receive support? And so I'm going to just stop sharing for 1 second, and I'm going to put this in the chat for you. And so this is where I'm hoping that we can work together on something called the Jamboard. And so the link is in the chat, and I would hope that everyone can see that. If someone can't see the chat, please let me know. And if this works well, it will bring us to this. And so this is called a Jamboard. And I'm just wondering, I'm seeing folks join on here. So we have 34 participants, and we have 6 folks coming on here. And this is, if you haven't used a Jamboard before, this is a fun feature of Google that can make your teaching and workshop activities a little bit more engaging. You are showing up on my end as, Roberto, can you see the Jamboard? Is that what's showing right now? Just want to make sure.
Yes, it is.
Okay. So you will see these little animals up here. So you're showing up as an anonymous dingo, armadillo. I can't see who Roberto is, for example, on this slide. And so we're going to ask in the next 25 minutes is for your participation to go through a couple of questions that we have for you. But let me run you through what a Jamboard is and how to use it. Okay. This is our character, Sam. Sam is whoever you want Sam to be. So Sam could be you navigating the healthcare system. Sam could be your child. Sam could be a patient that you've had. Sam could be a figure of your imagination if you're a policymaker and imagining what it would be like for someone to go through the healthcare system. So please think about who Sam is in your mind. On the next set of slides, we're going to ask you questions. And on this side feature here, there's a pen, there's an eraser, and there's sticky notes. And so sticky notes are things that you could add. So if you had for example, I'm just adding Sam is fun. This is my little note here that I want to describe Sam. It will come up here. And so this is not relevant to what we're about to do, but I'm just showing you how this works. You can also add an image if you feel like, if you're feeling more about pulling in an image to answer the question, or a text box. Okay. So let's try it. Roberto, I'm relying on you to be game. I think this is your first time.
My first time using it?
Yeah, so up on the top, you should also see a little 1 of 8, and there's an arrow. And so you can move to box number 2 and join me on box number 2. And what we have here is the first question about, let's just think about Sam and think about, how does Sam enter a clinical pathway? When does their care experience begin? And I've put two up to get us started, but there's many different other ways that Sam could enter a clinical care pathway. And if you want to just yell it, I can make your sticky note too for whatever works, but let's see if this can work.
I'm doing some right now.
All right. And you can move them around as well. So this is excellent. Okay, so we have a couple of school counselors. You guys are pretty good for folks who. So many different ways. So we're talking about, Roberto, is there anything that's striking you here as missing?
I'm adding here mental health care outpatient, which can look very different from province to province. Oh, I see. MHSU consultant. Yeah.
Someone here has peer counsel. I'll add that. Can Grace, I'm wondering if you could tell us what peer counsel is. Is that through peer support, or is that's a new term for me? You can put it in the chat too. So basically, there's, oh, okay, meant counselor. Perfect. So I'll put you in this area. Great. Have I seen schools anywhere, Roberto? I think that's just one. Let me just add that one.
So it's the very bottom left, right under
Oh yeah,
Sam's.
school counselor. That's right.
Mhm.
Okay, so lots of to remember to keep moving them because they're on top of each other. So we typically, in a lot of ways that it's been discussed today, has been actually coming through the emergency department or coming through a specialist service. But you've mentioned a lot of different other ways that folks can enter care, and the concept that any door is the right door is really one that the province is starting to talk about. But you can think about already the complexity of how does the right door lead to the right treatment for that person with these many different approaches. So we have street nurse, emergency department, primary care, foundry, crisis services, corrections, the justice system, outreach workers, friends, emergency medical services. Really, anytime that person has reached a point where they're seeking out care, family member is important. These are really quite critical. Okay, so it's complex from the beginning, and so we're not talking about a linear journey and one journey that fits all. That the point of entry, just the beginning, is very different. Feel free to add, but for time we'll move to the third slide, so 3 of 8. This is a slide that Dr. Sassy and I would love you to think about. What is important at this screening phase? So what are the things and the considerations for SAM that are critical at this phase, the first point of where they've come into the care trajectory? What are the things that are important at this screening phase to think about? Oops. That's great. Roberta, do you want to read these ones?
Yes, I'm trying to cluster that into
Oh, you're,
themes, right?
are you doing, you're doing an analysis already. That's good.
Yeah. So there's some that are about um, engaging and making sure that the goals of the youth are heard. Uh, Seems interesting activities. I'll put this one here too. Yeah, those would be here as well. Some patient goals. Here in the bottom, put the other conditions, mental health conditions. History. And here, this corner, I'm going to put family support, support system. Support.
Try and put that out. Feel like I'm about to mess up your coordinated system here, but there's a bunch in the chat too that I will add in there.
Yeah.
So I think one of the things that strikes me here, Roberto, is there's a range of making sure that person's safe and understanding their safety risk, all the way to understanding the full range of their needs. And I think based on how they come into care or what that looks like, there's also some really important comments that it's about just establishing relationship, maybe not giving so much information at that time, depending on their health state, seeing if they're stable, or is it actually an opportunity to have a full range of conversations and talk about everything from housing to their goals to social determinants of health and trauma history. But I think conditionally the theme underneath it all is no matter what, to have a non-judgmental attitude.
Yeah.
What do you think?
And no, I think it shows the complexity of establishing something like this, right? Because when on my simplistic mind, when we talk about screening, the first thing that comes to my mind is a simple screening instrument. If you score above a certain value on that screening instrument and you're between ages this or that, you're offered to be part of a clinical pathway. But you can see that approach is so restricted, and that might miss the opportunity of understanding the needs and desires and wishes of people entering a clinical pathway from the moment of screening to begin with. So the depth that we need to understand the person embarking into a clinical pathway is quite significant, rather than just a simple screening, yes or no, to enter a particular clinical pathway.
Before we get to the next one, I think the idea of like success would be that they're willing to come back for another appointment. And I recently was in the emergency department because I broke my ankle and I sat there for a while waiting for it to be fixed. And I saw several times that a couple of people are being approached for OAT initiation, and there was no follow-up. Sort of wondered what was happening after that, and I was like, no, but what really building that relationship is a great outcome that you've outlined there. Oops, a bit of feedback. I think coming from Grace.
Yeah, I'm not sure, Grace.
Right. So we're going to go to the next one, and we're going to start moving just a little bit faster. But then what do we talked about what we think we need to support Sam with. But what do you think Sam's goals for care are at this point of entering the clinical care pathway? We need to ask Sam, of course. Yes. And I guess I'll just riff off of that because our goals for the healthcare system and what we measure, and Roberto, maybe you could talk about this. Safety is like absolutely important. But what we measure is, number of emerge visits. We measure the number of overdoses, the number of deaths in our province. Do we measure like what SAM's goals are, and did the SAM actually achieve their goals for care? And I think that's really interesting that this is coming up a lot. Like, we need to ask Sam whatever he wants. And I think sometimes the goals that we have and what we measure about our system being effective are often not matching what the client is telling us, the patient is telling us. But there's obviously the important goal of safety, and that would be from the family's perspective as well, often, that safety and stability is the first goal of care. But then that has to be contextualized in what the next steps are. So start where the client's at is a really good point. So I'm going to go to, it's just kind of linked and linked to this for Sam, but really, what do you discuss about what treatment's looking like at this point? So we've understood Sam's goals. We understand that they want to begin this clinical care trajectory. What are we talking about beyond just OAT initiation or anything else beyond OAT initiation? What are we talking about? And also, who do you think needs to be in the room? And that's, sorry, we're on number 5 now. If you just have to move to number 5. I'm not good with time, Roberto. I told you that.
Yeah, I think we're gonna do for the next 6 minutes. That's I think what we have. Yeah.
So you can add that, and then I just I want to sort of show you what the next steps would be as it gets more complex, and the clinical care pathway, these steps, and having these conversations about who's in the room and what are the goals for care, and what is the outcome of care is really important, because ideally you want your clinical care pathway leading to outcomes that are important to the person, their family, their community. And we do tend to have a system that's about preventing death or preventing further overdose. But how do we move to a system that's actually aligned to that and what's important to the client and helping them thrive in their communities? So Roberto talked about common components that you could build in a clinical care pathway. And we've just given examples of how you could put this all together. And so I've made this really, really crude of just thinking about maybe 4 visits, maybe 5 visits. But these are types of questions that you could build with your community, or even with your family, or for you if you're going into care. On visit number 1, who's going to be present at that? What is access at this point? So where are you in that care journey? What are the goals for care, and how are they discussed? And really what the desired outcome is. So visit number 1 could be that it's not OAT initiation, it's talking about the overdose experience and debriefing and bringing in the family and setting up a series of new visits, and building relationship could be the outcome of visit number 1. Or maybe OAT initiation is actually the goal for care at that point. This is a critically important point of that visit for care. But really thinking about this and thinking about over time is ways that you could do this. And if you use a Jamboard or just even sticky notes or old school back into your community, sitting around a table and thinking about what that journey could look like, but also thinking about where it can go wrong. And so what if the goal for care was to come back to visit number 2 and the person didn't come back? What is your follow-up as a team? How do we support that person? Because often not coming back doesn't mean they were so terrifically satisfied with your services they didn't need to come back. It means that the care was not aligned for their needs. And then the last slide, I just want to give you, don't panic. This is just something to look at. And I can make this a little bit bigger. Actually, I'm going to make this one bigger first. This is from the New England Journal of Medicine, showing a clinical care pathway for OUD. And you can make this bigger too on your own. But I just want to show that, they thought about the individual with OUD, and it's right away with established, mild, moderate, severe. And there's different types of components of what should, as Roberto said, should be done in these various components. But just with the stuff that you've also talked about recently, there's a lot that's missing in this pathway. So this is New England Journal of Medicine pathway, and all the things that you talked about, the SAM's goals and social determinants of health and housing, are not in here. And so these are things where often the pathway doesn't work because we haven't built in the client's goals right from the beginning. But this is currently best practice. The other thing that I wanted to highlight is this is sort of one that I'm working on for a different study, and my area of research is in, I don't know if this is going to work if I do this, yes, is in measurement. And so really thinking about, so that journey can also be broken down throughout the first visit. So they've come to the first desk. What does the pre-screening look like? What are the types of, like you said, Roberto, how are you going to classify them as mild, moderate, severe, or based on what their psychosocial needs are? Really thinking about your clinical care trajectory as you start to build it out as well. Where are you collecting data along that care trajectory, both qualitative and quantitative, so that you're understanding that the trajectory is fit for purpose for people who need it. So those are, that was a speed direction, but this is really the takeaway that we hope that at least some of these questions can guide you in your work. And we have 2 more slides. This is my ankle. Sorry, I've had a lot of ankle injuries, and so I keep referring back to this, but this is simple. And at the end of the day, this is the Ottawa ankle rules that everybody follows. When somebody comes in with an ankle injury, and really, can we get to that point in the province where you have a developmentally, culturally sensitive approach to OUD clinical care pathway development that's fit for purpose for communities? Maybe this is building off evidence like this, or it's building off things that may work for your community that help you evaluate impact of whether or not what you're doing is working. So in summary, clinical pathways are critical. They help standardize the treatment, they improve outcomes, but they really need to be community and person-centered. And that's really the takeaway that we hear from a lot of the qualitative work in this province, as we continue to see these outcomes that are sad. And it often gets back to, I felt alone, or the system was too complex. I didn't know what the map was. And so how do we help build the maps for our patients and for our service providers, so that they feel like what they're doing is good work, and it's connected, and it's leading to strong multidisciplinary collaboration, innovation, and sharing of new ways of improving patient and family outcomes for folks in our province. And so that is it. And Roberto, any concluding thoughts?
No, I think this is when you start planning and thinking of a clinical pathway, make sure that you reach out to your partners, because as Sky was showing, you're going to come up with a pathway where you might be able to deliver 10, 20, 50, 70% of that complex pathway. The other components might not come necessarily from your agency, your institution, your program. And that's the moment where multidisciplinary and multi-site and partnerships are going to be so important. So this is complex work. It's a big task. And the more we can do together.
Thanks, Roberto. We'll pass it back to the organizing committee, and I think we only have the closing panel left. So thank you to Marisha and Dr. Kraus for helping organize us today, and thanks for your participation on the board. It was fun.